Welcome, everyone, and thank you so much for joining us today. I'm Sue Peshin, and I serve as President and CEO of the Alliance for Aging Research. And for those of you who don't know us, the Alliance for Aging Research is the leading nonprofit organization that's dedicated to accelerating the pace of scientific discoveries and their application in order to improve the universal experience of aging and health. We do work in both health education and advocacy on a variety of age-related issues. And the Silver Book program that you're going to hear more about in a minute from Lindsay Clark, who is our Vice President of Health Programs, is one that crosses both education and advocacy, as do a lot of our issues. We're thrilled today to release the Silver Book Cancer Volume and Fact Sheet, and to do so with our fabulous partners, the Personalized Medicine Coalition and the American Association for Cancer Research. Thank you for partnering with us today. We also want to thank Pfizer Incorporated for their generous support that allowed us to produce this latest resource in the Silver Book series. We could not have done this without you. And I'd also like to thank Congressman Alan Grayson for hosting us today. The Alliance is releasing this volume because cancer is such a huge and pressing problem, particularly in the older adult population. This year alone, more than 1.6 million new cases of cancer are expected to be diagnosed. And while cancer can strike at any age, it is largely a disease of aging, with around 78% of all cancer cases diagnosed in people aged 55 and older. So it's not surprising that the incidence of cancer will grow, reaching 2.4 million new cancer cases by 2035. And the costs will also increase accordingly, from $290 billion in 2010 to $458 billion in 2030. We cannot afford to let cancer continue on its current path, but fortunately, most experts agree that this is an exciting time in cancer research. We are seeing major breakthroughs in how we prevent, treat, and cure cancer, all of which are becoming increasingly personalized. Groundbreaking advances in immuno-oncology, a field that uses the body's own immune system to fight cancer, are causing a paradigm shift in cancer treatment. We're here today to focus the conversation on the staggering burden of cancer and the tremendous personal and societal value that innovation is bringing to the field. And it's now my pleasure to hand things over to Lindsay Clark, the Alliance's Vice President of Health Programs and Director of our Silver Book program.
Thank you, Sue. Good afternoon, everyone. I'm Lindsay Clark, Vice President of Health Programs at the Alliance, and I'm very pleased to be releasing today's 10th volume and 8th fact sheet in the Silver Book series. The Silver Book Chronic Disease and Medical Innovation has become a trusted resource for policymakers, thought leaders, health advocates, and reporters across the nation who are looking for easy access to well-cited statistics on the burden of disease. By also highlighting data that showcases the value of innovation in reducing those burdens, the Silver Book promotes conversations and national policies that turn to investments in research. This is especially important at a time when 10,000 Americans are turning 65 each day. By 2030, 1 in 5 Americans will be 65 years or older, and many will not be living in good health. In fact, 80% of today's Americans aged 65 and older have at least one chronic condition that often leads to extensive hospital stays, disability, countless medical visits, lost independence, often financially overwhelming expenses, and death. The silver tsunami of age-related diseases and conditions could also cripple our healthcare system and economy unless we invest now in medical research and public health solutions. So the Silver Book highlights this data by extracting key findings from influential reports and studies in the field and providing the essential information in one easy-to-use and well-referenced resource. This almanac of sorts currently features more than 2,000 facts and figures from more than 600 sources and covers a range of topics including Alzheimer's disease, cardiovascular disease, healthcare-associated infections, infectious disease, osteoporosis, Parkinson's disease. I could go on, but I will save you. All the facts in the Silver Book series are available online at silverbook.org, and when it's possible, we link it to the original electronic version of the source. Today's volume of Cancer is also available online, along with the fact sheet that includes policy recommendations, which we are releasing in partnership with the Personalized Medicine Coalition and the American Association for Cancer Research. And I want to give special thanks to Daryl Pritchard and to John Retzlaff for partnering with us on this. This accompanying fact sheet takes many of the facts from the larger volume and turns them into visually interesting infographics that we hope help frame the broad policy recommendations. And both of those resources are included in your packet, so if you didn't get one, please pick one up on your way out. So this volume includes data on breast, lung, colon and rectum, and prostate cancers, which are the most common sites for cancer in Americans age 65 and older. Innovation data is also obviously an important part of the resource and highlights the fact that cancer research is moving forward in leaps and bounds. Because of progress that has already been made in the field, the 5-year survival rate for cancer has increased 40% in the last 40 years. There are now 14.5 million people in the US living with a history of cancer. And one study from economists at the University of Chicago found that investments in cancer research since the 1970s have generated $1.9 trillion in value to society. So this is obviously a critical conversation that we're having. Before I turn it over to our next speaker, I want to give thanks to the Alliance team who helped make these resources and this event happen, especially to Kate Reiner and to Sarah DeGiovanni. It's my pleasure now to introduce Daryl Pritchard, who's the Vice President of Science Policy at the Personalized Medicine Coalition, and who so graciously agreed to be a part of our briefing.
So welcome everybody on a rainy day on Capitol Hill. I'm Daryl Pritchard, as Lindsay mentioned, with the Personalized Medicine Coalition. And the Personalized Medicine Coalition would like to thank the Alliance for Aging Research for the opportunity to partner with them on this Silver Book and on this important briefing. The Personalized Medicine Coalition, PMC, is an education and advocacy organization representing all of the different stakeholder communities in the field. PMC works to overcome barriers to personalized medicine in science, policy, and business. So we'd like to thank Sue Peshin and the entire AAR team, and especially Lindsay Clark, who really spearheaded and led this effort for both the Silver Book and this briefing. Excellent partner to have. We'd like to thank Dr. Cohen and Beverly Hyman-Feed for bringing their perspectives on cancer care to this briefing so we can all get a glimpse of what it's really like in the battle versus cancer. Thanks to Congressman Grayson, and thanks to all of you who are attending for your interest and prospective contributions on this issue going forward. So I just have some brief introductory remarks before I turn it back over to Sue. If you pick up a newspaper or tune into your nightly news or blog or post or tweet or whatever you do to absorb media, you can't help but notice the increasing amount of attention on healthcare, especially in the growing costs associated with doctor visits, hospital care, and for new drugs and medical technologies. The unsustainable trajectory of healthcare spending does involve increasing costs of medical services and products. However, a much more important factor, as Lindsay just mentioned, is an increased prevalence of illnesses and disease due to an aging population. And Lindsay told you the stats on how our aging population is growing and will continue to grow. And this becomes our most pressing challenge in healthcare. Nowhere is the trajectory of the burden of disease and the associated healthcare spending more clearly illustrated than with cancer care. The Alliance for Aging Research's Silver Book Cancer is being released at a critical time for our understanding of the burden of cancer, its disproportionate impact on older Americans, and on the promise of new technologies, which is what I want to focus on. So the solution to the problem likely rests with the development of new technologies, in particular, personalized medicine and oncology. The PMC is confident that personalized medicine can bring earlier detection and better treatment at reduced costs. And we're committed to advancing personalized oncology care through education and awareness, policy development, and advocacy. It's a very exciting time in personalized oncology care. Personalized cancer treatment strategies can help patients identify their own susceptibilities to cancers, allow for earlier detection, allow for safer, more effective targeted therapies, thereby getting the right treatment to a patient at the best possible time, provide more precise monitoring of the molecular changes in a patient's condition post-treatment so that the risk of recurrence can be met with appropriate interventions, while at the same time increasing the efficiency of the healthcare system by improving quality and accessibility and putting patients at the center of their own care. So with continued research, education, and policy development, this is the future of cancer care, one with reduced burden and more effective management of disease at lower overall healthcare costs through personalized medicine. This Silver Book helps bring this message to thought leaders and decision makers, and I'm excited to be a part of this briefing today. So welcome, and let me turn it back over to Sue Peshin to introduce our distinguished speakers. Thank you.
Thanks, Daryl. I'd now like to introduce Dr. Harvey J. Cohen of Duke University. Dr. Cohen is a professor, director of the Center for the Study of Aging and Human Development, and chair emeritus of the Department of Medicine. Dr. Cohen co-chairs the Cancer in the Elderly Committee for the Alliance for Clinical Trials in Oncology. He is the current president for the American Federation for Aging Research, also known as AFAR, and a friend of the Alliance, and a past president of the American Geriatric Society, the Gerontological Society of America, and the International Society of Geriatric Oncology. Dr. Cohen is also a leader in the cancer aging community of the American Association for Cancer Research. You can check out more of his impressive credentials in the full bio that's included in your briefing packets. Please join me in welcoming Dr. Cohen.
Thanks, Sue, and thank you to the organizers and to all of you for being here and to allow me this opportunity to speak with you today. Clearly, I don't have enough to do because I've been spending too many time outside my day job. But just to put this in context from my background, my original training was in oncology, and then now, well over 30 years ago, through a series of unplanned circumstances, I got more and more involved in the area of geriatrics and gerontology. And in the interest of combining those two interests, I've maintained a focus in what has now come to be known as geriatric oncology, essentially the oncologic care for older people. And that's a subject that's dear to my heart and one I want to talk with you about today. I just realized there is a generation gap here. I was noticing Sue's and Daryl's notes, and they're all on nice typed stuff. I've got these handwritten notes. My kids like to say I don't have a smartphone, I have a dumb phone, and that is true. But hopefully the information will be useful. So you've heard some of the data that really brings us here today, and it's really this interface of two demographic trends, which you've heard a little bit about. And I don't want to numb you with numbers, but I want to just put that in a little different context. And that is that the number of people over the age of 65 is going to more than double over the next 30 to 40 years. And more impressively, the number of people over the age of 75, 85, 95 are increasing at an even more rapid clip. And so we are clearly an aging population in this country and throughout, in fact, the developing world. As a result, in part of that, because cancer is a disease of aging, and it's a disease that actually increases progressively with each succeeding decade until people are at least at the age of 90. And because of that, about 60% of all cancer diagnoses occur in people over the age of 65. And over 70% of all cancer deaths occur in people over the age of 65. So this is clearly a disease where aging and cancer interface. Happily, as a result, in part of many of the successes of the past and the increases in longevity overall, cancer survivorship has been affected as well. And so over 60% of current day cancer survivors are over the age of 65 and 50% over the age of 75. And many of these people have been survivors of cancer for many years. And you'll hear from a very successful cancer survivor in just a few minutes. So this has come about from a number of things, but certainly a major part of this has been an impressive incremental growth that research in this area has produced. It has improved our approaches through surgical treatments. It's improved our approaches through radiation therapy treatments. But perhaps most impressively and of interest here today, it has really improved our basic understanding of the basic biology of the cancer process, what's actually going on when cancer evolves. And through that has enabled us to really start targeting this underlying basic biology as a way to think about treating cancer. So there's been a lot of recent excitement in this area. This is an area that is really hot, as Daryl implied, and I think if you see any of the news magazines, you wouldn't be surprised. And that excitement has come in many areas, but in two particular that I just want to highlight briefly. One has been in the development of what have been called targeted agents. They're agents that are for systemic therapy that are directed at unique aspects of the cancer cell that are either totally unique or at least dominated in the cancer cell and not as much in normal cells, allowing these therapies to more effectively, quote, target the cancer cell. They're not perfect by any means, but their targeting is much more impressive. An example of that type of therapy are ones that are directed at particular enzymes, for example, or molecules within the cancer cell, such as one which is really was the first, in a sense, called Gleevec or imatinib, which is a treatment for chronic myelogenous leukemia, which very specifically targets molecules within that cell and has revolutionized the treatment of that disease. More recently even has been what Daryl alluded to as immunomodulatory therapy. And these are therapies that try to take advantage of the body's own immune system. We've known about, quote, immunotherapy for years and years and years. It goes back a long time. But it has been largely unsuccessful over many years. And that's because we didn't really understand well what the basic mechanisms are that might allow that kind of therapy to work. And over the past decade or so, we've really started learning that. And so two types of therapies have been developed. One are antibodies that are actually directed against molecules on the surface of cancer cells. An example of that is a drug called rituximab. It's against a specific antigen on the surface of lymphoma cells and has revolutionized the treatment of that disease. A second type, more recently, has recognized the fact that cancer cells are pretty smart. And they've figured out ways to evade the body's natural defense systems that might be directed against it. And so they have developed molecules in their cells that migrate to the immune system cells, the so-called T cells, that are going to fight that invasion and block their ability to fight that cancer cell. And that's one of the main reasons why many of the therapies have failed in the past. More recently, we've learned ways to actually inhibit that blockade and free up the immune cells to be able to actually attack the cancer cells. These drugs have been called checkpoint inhibitors, and they actually have shown some dramatic responses, effectiveness, unfortunately often short-lived, but the proof of principle is starting to emerge, and these drugs are now starting to move into past clinical trials into general use in cancer patients, and have been used predominantly in melanoma, malignant melanoma, and more recently in lung cancer. And so there is a bright future, we believe, for these types of drugs, although a lot more work is going to be needed to get them to be fully, broadly active and fully effective. So this is all great, and so everything should be rosy, but everything's not quite that rosy. We need more work in this area, and we would urge support for that kind of basic fundamental work to refine our knowledge about the cancer cell and how these drugs can be tailored better. But we have a problem, and one of the problems is that the way we learn how to use these drugs as they're being developed is through clinical trials. And what we have found and known for some time is that the older population is woefully underrepresented in clinical trials. So, for example, the patients over the age of 65, remember 60% of all cancer in those patients are grossly underrepresented in trials. And a recent IOM report, which was focused on this particular issue of treating older patients with cancer in our aging world, noted that only 20% of patients that clinical trials had only 20% representation of patients over the age of 70, despite the fact that they represent 50% of the cancer population. So we're just not learning well enough about how to treat the older cancer patient. And that's an issue that we really need attention to. In fact, the IOM report urged action in this regard, and one of the actions that was urged is relevant in this room because it was urged that Congress authorize the FDA to have more authority to require that any clinical trial being studied have a representative age population within it before a drug or a new treatment could actually be approved for care. And this is something I would strongly echo. So the older population, this wouldn't be a big problem if older population, older people were just the same as all the younger people. I can tell you from personal experience that's not true, and I know it from professional experience as well. So as people age, a number of things happen. There's changes in physiology, organ functions change. There are accumulation of diseases. You heard about the fact that the older people tend to have one, but tend to have often multiple diseases. There are changes in drug handling. There are many different things that happen. And what that creates is a very heterogeneous population. I often tell our trainees at home that if you want a challenge in medicine, you don't work with 30-year-olds, because they're all the same. Basically, you've seen one 30-year-old from a medical standpoint, you've seen one 30-year-old. But 80-year-olds are another story. You've seen one 80-year-old, you've seen one 80-year-old, because there's so much heterogeneity and so much difference from person to person, which requires a different approach when we think about cancer treatment. So this heterogeneity is something we have to address. And in recent times, research has shown us that there may be ways to do that. And one such way has been the application of what's called comprehensive geriatric assessment to the older cancer population. And here what we're doing is doing a multifaceted evaluation of an older patient, their medical situation, their social situation, economic situation, psychological situation, to get a fully rounded view of what that patient is like before we start thinking about what therapies we're going to offer. And I think this approach has the potential to really help us tailor treatment better. Often we talk about personalized medicine these days as thinking about cancer genetics, and that's sort of where the main focus has been, and it's very appropriate, it's important. But there's more to personalized medicine than just the cancer genetics, and what I would suggest is as we learn more from our geriatric assessments and combine that with our knowledge of the tumor biology, and further combine that with increasing knowledge of the host biology, the patient themselves, and biomarkers of function and of aging, we can create the ultimate in personalized cancer care. Not just the genetics, but the whole person personalized. And that, I think, is a goal that we really should strive towards. And research in this area is something we urgently need to have more of. And our goal here would be not simply just to extend survival, but to actually improve quality of life as well as the survival. And as it's been said, not just to add years to life, but to add life to years as well. And I think that's a goal most people would empathize with. So research in the area of cancer biology, as we mentioned earlier, has really started revolutionizing our approach to care. But there's another revolution happening, and that's our approach to research into the understanding of the basic process of aging. Just as we're trying to learn what the basic process of cancer evolution is, we're learning about what the basic process of the aging process is. And here we've started understanding what have been called the hallmarks of aging, individual processes and programs that seem critical in the aging process. Things like the dysfunction, increasing dysfunction of our mitochondria, which are the metabolic motors of our cells, or the fact that senescent or aging cells in the body can actually secrete molecules that are pro-cancer producing, and may explain in part the reason why the incidence of cancer increases progressively over our lifespan. So all of these could potentially be targets for cancer treatment or prevention, in fact. Indeed, as we increase our understanding of the basic biology of aging, the potential that we could actually delay, quote, aging, but more importantly, delay the onset of age-related diseases really starts becoming possible. And there's a whole approach now that's been called the Geroscience Initiative, which is geared at this possibility, looking at research in the basic process of aging as a way to think about delaying that aging process, and in doing so, delaying the diseases of aging, cancer as well as others. If we could do that, in fact, it would actually dwarf the financial, not to mention human value savings that reducing cancer, for example, by 1% could do, which is enormous in and of itself. But imagine if we could actually delay all chronic diseases of aging by a year. This would produce multiple billions of dollars of savings and value and untold increase in value of human life. So this, I think, is a real area that we should put some stress on. And there's a lot to be done here. Some of these studies have been done in animal models. There's a proof of principle there. It looks like you can actually do this. Human studies are on the drawing board to start trying to do this in people. And the results could be dramatic, but a lot of work to be done and support needed, obviously. American Federation for Aging Research, which as you heard, I'm current president of, helps to fund some of this research, but they're a relatively small group, and this is a large one, and so we would sort of urge Congress and others to get behind this movement as well. I mentioned earlier that we've got an increasing number of cancer survivors, and they're increasingly an aging group of cancer survivors. And so this is a story of success, obviously, but sometimes with success comes challenge. And we have challenges in this area. We've come to realize that with cancer survivorship, there are late effects of cancer treatment, late effects of the cancer itself, and in the older cancer patient, adding to that the effects of the aging process, accumulation of other diseases, et cetera. So for the older cancer survivor, this is, in a sense, at least a triple whammy. I mean, there's a lot of things happening in that circumstance. And we need to figure out ways, and we need research to help figure out ways, the best way to care for that group of people. I believe that one of the targets here should be the merging of the skills of the oncologists and of the geriatricians to really build programs that can help manage such folks. And the IOM report speaks to that issue as well. And finally, I want to point out that to do all that, we need a workforce that's prepared to do it. And when I was privileged to be on that IOM committee, and when we were looking at this issue, it turned out that the workforce we currently have is not really well prepared for that, and we need to address this. So we need ways to support training that will provide the care providers who understand how to treat cancer, but also understand what the issues are as people age, and can bring both of those perspectives to bear on treating patients. This is, I believe, an opportunity to support joint training programs, for example, in oncology and geriatrics, that could produce people with that kind of expertise. There have been a small number of such people trained in this country over the last 10 years or so, but we need many more. And we need it not only for physicians, we need all disciplines that care for cancer patients to have this joint view of training. Nurses, social workers, the technicians, everybody dealing with the cancer patient needs to have that dual view to be able to care best for the older cancer patient. So, and then we'll need ways to study whether these approaches work. And so I think we have a great agenda to address before us. So there's a lot that's been accomplished. This is an era of unprecedented growth in the science and clinical knowledge that we have, but there's a lot more to learn, and to capitalize on this growth, a lot more to do. And I want you to remember that for everyone in this room, it's your parents and your grandparents we're talking about here. And in fact, recall a sign in a North Carolina coffee shop that I saw a while back that said, don't criticize the coffee, you may be old and weak someday yourself. So it's your future selves as well that have to be thought of here. And we all have something, all have a vested interest in something at stake. So I hope that you will take some of the things I said to heart and go out there and join the crusade that we're all on to better address, more research, to improve our care for cancer patients in general, and certainly for the older cancer population. So thank you very much for listening.
Thank you, Dr. Cohen. That was excellent. And there are two quick comments I just want to make in response to Dr. Cohen's statements. One is that the mention that he made of geroscience and this effort to look into the underlying biology of aging as a cause of age-related chronic disease is actually becoming a very successful effort right now at the National Institutes of Health. There is something called a trans-NIH geroscience initiative that was started about 2 years ago and now includes 20 of the 27 institutes and centers at the National Institutes of Health. And actually one of the most active centers that's involved is the National Cancer Institute because they really get the link between the underlying biology of aging and the development of cancer. So I encourage you to learn more about that effort. We're trying to see if there is an opportunity to fund a geroscience effort not only within the National Institutes of Health but across the federal government. And the second thing I wanted to mention is this issue around clinical trial recruitment for older adults. The National Institute on Aging actually has a pilot program going called Recruiting Older Adults into Research, which is shorthand for ROAR is shorthand for the program. And right now it's just limited to a couple of conditions, but they're really looking to expand it. And on both these issues, I wanted to encourage offices and groups in the room to submit comments to the White House Conference on Aging and to encourage you to encourage them to include these topics as part of the White House Conference on Aging, because there's a lot of focus right now in their healthy aging piece to really talk about sort of nutrition and exercise and the, sort of the onus on the individual as they've typically done in previous White House conferences on aging. We really want to encourage them to talk about science and research and this issue of educating folks about the importance of participating in clinical trials. So it's just a very quick pitch there. Now I'd like to introduce Beverly Hyman Feed, who's going to add her experience as a patient to the conversation. Beverly is an author, artist, poet, photographer, and cancer survivor. I'm going to leave it to Beverly to tell you more about her experience with cancer, but I do want to tell you about how she's become a powerful advocate for cancer patients. Beverly is the author of a book for patients with cancer, as well as a book for children who have a loved one dealing with the disease, which she co-wrote with her granddaughter. Beverly, and there's actually, I think there's an issue over on the table if you want to take a look at it. Beverly not only speaks about her experience at events like these across the nation, but has also shared her story in a documentary that she wrote and produced. And she's currently at work turning her blog, Aging in High Heels, who doesn't love that, into her third book. And please join me in welcoming this amazing woman to the podium.
Thank you so much. First of all, I'm so honored to be on the same panel with Dr. Pritchard and Dr. Cohen. That's really an amazing thrill for me. You both are so impressive. I'd like to thank Lindsay Clark, the Alliance for Aging Research, for bringing me here. And the Personalized Medicine Coalition, and the American Association in Cancer Research. And thank you to Linda House, Lynn Silbert, and Sheila Hammer from the Cancer Support Community for all their good work and for passing my name along to get the ball rolling. I'm very honored to be here today. I could say that my cancer odyssey started 22 years ago when I received my first diagnosis, but that wouldn't really be true, because it really started the year I was born, the year my grandmother died of liver cancer. 27 years later, my mother died of colon cancer, and a few years after that, my eldest sister died of ovarian cancer at the age of 54, and then my middle sister died of liver cancer at 63. No woman in my family ever reached 64. Unfortunately, I lost a niece and nephew at 61 of throat cancer and brain cancer, and 2 first cousins of lymphoma and lung cancer. Needless to say, cancer ran rampant in my family. When I received my first diagnosis, and I was 50 years old, and they told me it was uterine lining cancer, that's a little cancer. That's kind of like being a little bit pregnant. I was delighted because it meant it was easily healed. I had a radical hysterectomy. All my cells were clean, my margins were clean. I had no treatment. I was free. I was clear. For some reason, I got away with this. I couldn't have been happier. So when 12 years later, I had some stomach pains that kind of doubled me over, just for a moment, I thought I picked up a bug. My husband and I were out of the country, and food made me ill, and I felt nauseous whenever I would finish a meal. And I had that funny little stitch pain in my abdomen. We agreed that when I came home from this trip, I would go see my internist. I did, and he told me to lie down on the table, and he felt my stomach. Ooh, that hurt. He said, "How long has that been going on?" And when I heard my answer, I realized I must have been living in fear after all. I said, "About a year." He said, "That's not right, Beverly. We have to take an x-ray." I argued with him. I told him I had been taking good care of myself. I was fit. I ate well. He said, "We're going to take an x-ray. Do it for me." I did. There was a large mass on my abdomen. I stopped arguing. He then ordered a colonoscopy, an endoscopy, blood tests, tumor markers, biopsy. Nothing showed up. "You see," I said, I'm well. It was a bug I picked up." He said, "Let's do one more test. We'll put you under and do another biopsy, and this will give us time to look around." We went down to UCLA for that test, and as I awoke from the anesthetic, I heard my doctor telling my family, "This is very serious. She has 8 large tumors in her abdomen. This is Friday. I want her in the hospital by Monday for 4 kinds of chemotherapy into the site, 24 hours a day, 3 weeks at a time. She'll become very ill. When she gets back up, we'd like to resection her stomach. It's a long, arduous operation with a long recovery. And when she recovers from that, if we still have any tumors that we see, we'd like to put her back in the hospital for 4 kinds of chemotherapy for 3 weeks at a time again." I don't know how I knew, but I did, and I said, "I want more opinions." My team went to work. By the next week, they had an opinion of a triage at City of Hope. 3 doctors there looked at all my CAT scans and papers, and they said, "We agree with the doctor from UCLA." But they added 2 chilling sentences. Number 1 is that you better hurry because you'll miss your window of opportunity. You've got to do this immediately. And when asked what would happen if I didn't do this regimen, they said, you have 2 months at best. I don't really remember leaving City of Hope. I don't remember how the meeting ended or getting into the car, but I do remember hearing a lot of crying. And I'm not sure if it was mine or my family's, or both. But my team had 2 more appointments set up. By this time, we had found out that I did have sarcoma. And so they had an appointment with Dr. Charles Forscher, head of sarcoma at Cedars-Sinai, and Dr. Frederick Eilber, head of sarcoma at UCLA. Dr. Charles Forscher was the first doctor to go into my old slides of my first cancer and see that those contained cells were not so quite contained, that they had moved into my abdomen, thus creating the 8 large tumors I still live with today. He suggested by the time I get to Dr. Eilber, who he was going to work with on this case, that they would have come up with a protocol for me. The wonderful news about him going into the old cells was that now we knew it came from my uterus, thus making my tumors hormone receptive and hormone driven. So it opened me up to other options for treatment. This was thrilling. We walked into Dr. Eilber's office, and before we had gone there, I had had a meeting with my family, and I had said, these 2 doctors are my last appointments. If they don't come up with something that makes sense to me, I'm not going to do that rigorous treatment that those other doctors suggested. I was 68 years old at the time. I didn't know if my body could take it. I didn't know if I wanted to put myself through it. That I was just going to treat myself with natural nutrition and exercise and just ride it out so I could have quality of life with my family. Luckily, they knew how much this meant to me and they respected my wishes. So we knew what was riding on this last appointment. We walked into this office, and this doctor had all the papers strewn all around, the CAT scans, the PET scans, the x-rays, and he said, we're not giving you chemotherapy, and we're not giving you an operation. If the tumor board allows, we're going to give you a shot of Lupron that they give to prostate cancer patients, and we're going to give you a pill of Femara that they give to breast cancer patients. You have hormone-driven cancer. These are hormone blockers. The pill of Femara is approved by the FDA. The shot of Lupron is approved by the FDA, but together, for what you have, it's not approved. So this is an experimental treatment. We have to go before the tumor board to get this approved. What do you think? I said, I think it makes perfect sense. I have hormone-driven cancer. These are hormone blockers. This makes sense to me, and I'm willing to bank my life on it. They said, go home. We'll call you after we've gone to the tumor board and when the call comes. Tuesday morning, the call came from Dr. Forscher's office. They said, you have been approved by the tumor board. Come in for your first shot today. I did, and this summer, it'll be 13 years. Thank you. This truly has been the most powerful 13 years of my life because I've formed a passion. I formed a passion to get to as many cancer patients as I can and tell them, number one, get more than one opinion. Get 2 opinions, get 3. Keep going until you feel comfortable with what you hear and you feel is right for your body. Number 2, become co-captain with your doctor. He has hundreds of patients. You only have 1. Bring the knowledge of what your body is to your doctor. He brings the knowledge of medicine. You bring the knowledge of your body. Together, it's a perfect partnership. Eat right. Drink green vegetables, drink green juice, eat leafy green vegetables, exercise. Keep making goals for yourself, writing things down, write your feelings down. Let your family in, let your friends in. This is something you can do. You can be proactive in your disease. Years ago, my grandmother, my mother, my sisters, they were told what to do by one doctor. They listened. They did whatever it was. The doctor did the best he could and the best he knew. They laid down, and unfortunately, they died. Today, we are living in such a lucky era, all of us. I didn't realize, but at the time, I was on the cutting edge of personalized medicine. I was so lucky. I was so lucky to have two doctors that thought out of the box and were willing to give me something new, and I was so willing to take it. I was in the right place at the right time. How lucky I was. When Dr. Cohn was talking, I felt like he was talking about me. I'm that 80-year-old that he's talking about. This July, I'll be 81. And yes, I have cancer from the time I'm 68, but I'm leading a wonderful life. I'm a legislative ambassador for the American Cancer Society. I'm a hero of hope for the American Cancer Society. I speak all over for various organizations. It's my passion. And not only for cancer and cancer patients, but as I am an aging person myself, I like to go talk to aging people and tell them, be proactive in your aging. This has helped teach me. Having stage 4 cancer has taught me how to deal with the aging process. You can't just lie back and age. Our parents sat on a couch and smoked a cigarette at age 60. We know better. We know to exercise, we know to eat right, we know to be interested and interesting, we know to make goals for ourselves, we know to take whatever it needs to make ourselves active and relevant in this world. So my cancer, my stage 4 cancer, and now my myelodysplasia, which I was diagnosed with a couple of years ago, has helped me deal with my aging. And I feel that if we are all lucky, and if we are listen to our doctors and become co-captain with our doctors, we can live vital, strong lives through our 80s and into our 90s. I have been collecting quotes during my journey, and my favorite quote remains Emile Zola, who said, "If you ask me what I came here today to do, I came here to live out loud." Thank you for letting me live out loud with you today. I want to do so until my very last breath. Thank you.